Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners, and welcome back to another episode. Today, I am joined by Dr. Rhea Temmermand, PhD, CRNA, FAANA, a leading neuropharmacology researcher at Drexel University. Her work focuses on glutamate transporters, neuropathic pain, and developing non-opioid treatments. She's also an educator, textbook co-editor, and co-founder of Atomic Anesthesia. In this episode, we're talking pharmacogenetics, how your genes can change the way patients metabolize drugs, and why this knowledge is transforming anesthesia practice. Let's dive in. Hello, my favorite learners, and welcome to another podcast episode. I'm so excited today to have Rhea Temmermand here with me. We are talking about all things pharmacogenomics today. Rhea, thank you for being here. I appreciate your time, and so do all of our favorite learners. Can you just go into a little bit on how you got into CRNA education? Just tell your story.
Absolutely. Thank you, Dr. Gomez, for having me on the show. And yeah, I actually started, just like everybody else, as a clinical CRNA. I'd been doing research most of my nursing career since undergrad, all through being a CRNA. And one day I was working clinically, actually, in Augusta, Georgia. We were there for a one-year assignment. My husband was doing his fellowship in endocrine surgery. I was in the break room with a couple other CRNAs, and one of the CRNAs I was sitting around the break table with was Dr. Rhea Temmermand, who is assistant program director at Augusta University. And I just made a comment that said something like, yeah, I would be interested in teaching eventually. And he just said, well, why don't you just come and give a guest lecture? And that's how it all started. So I gave a guest lecture. I think it was about like out of OR anesthesia. And I mean, it was terrible. We were just talking about, when you start teaching for the first time and how bad it is. But I really liked the setting, the academic setting, and especially being a researcher as well. I knew that academia was where I wanted to head. So started as an adjunct professor and did a lot of simulation lab, and eventually went back to school to get my PhD in pharmacology and did a lot of teaching during my PhD. So obviously being in Pharm Phys taught a lot of pharmacology, taught a lot of trauma anesthesia because that is what I did clinically, do a lot of vascular and neuro anesthesia. And that's kind of where I gravitated to like a full-blown academic career. And here we are.
I love it. Thank you for sharing. I think it's so important, like we talked offline a little bit, to show students what a pathway can look like and how all of us have ended up where we are in academics and giving back to the next generation. So thank you for everything you've done for the next generation of learners. We're going to go into like a brief overview. So we're going to start really big and then kind of focus in on different topics in pharmacogenomics. But can you kind of speak to some definitions within this space and this topic?
Yeah, definitely. So a lot of times when we think about just pharmacology in general, we think about the two main pillars, which is pharmacodynamics and pharmacokinetics. But I would argue that pharmacology has three pillars, which is Pharm D, Pharm K, and then pharmacogenetics. And even pharmacogenetics itself encompasses a lot of other subcategories as well. And one of them we'll talk briefly about today is epigenetics. And that's an up-and-coming field in genetics and pharmacogenetics. But an overview of pharmacogenetics. So pharmacogenetics is essentially how drug responses differ in a population of people. And we look at genetics, genomics, and epigenetics as the basis for this variation in the drug response. So we look at a population of people, right? And in this population, they will have the same diagnosis and get the same prescription, get the same drug. But what ends up happening is essentially four different scenarios. The drug does something without side effects, which is what we want it to do. So the drug is beneficial and it's not toxic. But then you have these three other categories of drug effects that we don't want to see, which is the drug does nothing and it's not beneficial. So it's not toxic and it's not toxic. So it does nothing, not beneficial, not toxic, just nothing at all. The next scenario would be the drug does something, but then it has some kind of adverse effect. So it's beneficial, but it's also toxic. And probably the worst scenario, which is the drug does nothing, but it has adverse effects, right? So it's not beneficial, but it's toxic to the person. And really, pharmacogenetics looks at, well, why does that happen, right? And why is it that you have this same population of people that they seemingly look the same, they seemingly have the same comorbidities, the same diagnosis, so they get the same drug, but you get so many different kind of patient scenarios or patient outcomes. And there are really a lot of reasons why this can happen. So we look at some of these like external or these environmental reasons, right? It could just be something simple like the person is taking way too much of the drug or taking it in the wrong way. Their nutritional status, maybe they have low albumin, so that affects the way that the pharmacokinetics, right, how the drug is traveling through the body. Their volume status, polypharmacy, the types of drugs that are interacting with one another within their body, enzyme induction, inhibition, things that you've talked about before in your podcast, diseases of their kidney or liver. So that's a lot of kind of external reasons. But then pharmacogenetics takes it a step further and takes a look at how your actual genes, how that affects the way that your body responds to the certain drug. And I think a lot of times we think of it as variations in your metabolizing enzymes, but it can also be variations in the drug transport molecules, in the actual molecular drug targets. So like your GPCRs are not the same between person and person. There could be different splice variants with those proteins. So that's kind of an overview of pharmacogenetics. And I want to make a brief mention really quick about epigenetics too. So I think that a lot of people have heard this term being thrown around and don't quite understand what epigenetics is. So as the name suggests, because epi is usually like above or outside, it's changes that are just outside of your DNA that affect whether your DNA gets translated into protein or not. What happens with DNA, as we know, is that DNA can be kind of loose and uncoiled, or it can be kind of like coiled up and tightened up into like tight little chromosomes. And the way that it's coiled up is it's wrapped around these proteins called histones. And histones can be modified by certain molecules, like, for example, like methyl groups or acetyl groups, and that controls how tightly the DNA is wound up or how loose the DNA is. And DNA can only be transcribed and translated into protein when it's loose, but it can't be transcribed and translated when it's tight around the histone. So there are certain environmental changes that can occur, like changes to your diet or like your exposure to like pollutants or pathogens or even your age or chronic stress, that can create these epigenetic changes. And that also changes how your DNA, like I said, is like transcribed and translated, and that can affect drug responses. So that's kind of like a little subfield of epigenetics, of pharmacogenetics is this epigenetic field. Yeah.
I love that. And, we always say clinically in anesthesia, like, oh, we're tailoring to each patient. Like each patient is so different. Like I'm constantly telling students in the clinical setting that, that there's no recipe, right? And it's so different.
Right.
And so I think this is a great way to talk about that. Like we talked about offline also, we don't test patients necessarily for these things, but your wheels are almost turning thinking about these things in every case with every patient, because every patient truly is different, right? And their drug response is different.
Yeah.
So now we can kind of zoom into the liver and talk more about like the cytochrome P450 enzymes and how differences in that can change patients' drug response. Do you want to talk about the P450 enzymes a little bit?
Yeah, definitely. And I think that even before we talk about specifically the cytochrome P450 system is more looking at like, well, what exactly is causing this change in the metabolizing enzymes? And one of the things that we talk a lot about in pharmacogenetics are things called polymorphisms. And polymorphisms, essentially what they are variations that occur in greater than 1% of the population. That's the definition of a polymorphism. And there are several things that can cause polymorphisms. And probably the most common thing that causes it is called a single nucleotide polymorphism, an SNP, or we sometimes, as in the science world, call them SNPs. That's sometimes what they call them. What a SNP is when you look at your DNA, DNA is made up of nucleotides. Think about the letters, right? Like A, T, C, G. Those are nucleotides, and you need 3 nucleotides to code for one amino acids. One amino acid. And the amino acids are linked together into a string in that string, that primary thing starts folding into a 3D structure. And that's what makes up the protein, right? So you can have a single nucleotide polymorphism where even one of those nucleotides is exchanged for something else. It could be a mutation, something happens to your DNA, be exposed to radiation, reactive oxygen species, whatever. And that maybe you have an A that's exchanged for a C. Okay. So what essentially happens there is that can code for a different amino acid. And most of the time, this doesn't do anything. But if that amino acid is in a critical spot during the protein folding, the protein can fold abnormally. I think one really quick example of this is sickle cell anemia, right? That's just a problem with one nucleotide, but it's a pretty essential nucleotide that changes the protein, which changes the way that it folds. So you have an abnormal structure for the hemoglobin. That's one thing. It's this SNP. The other thing is you can have whole sections of your DNA that's either inserted or deleted. All right, so that's polymorphisms. Now, polymorphisms can affect an entire population of people, or it can really be confined to a specific geographical area or a certain ethnicity. And that's when we start thinking about several groups that kind of stand out that we can kind of predict how their drug response is going to be. I promise we're getting to CYP 450 in just a second. It'll make sense in just a second.
I believe you. I'm following down the trail.
Yeah. So there are certain groups that kind of stand out. We won't go through all of them, but some that kind of stand out are, for example, for sex. So women have a more rapid clearance of their drugs that are metabolized by, just in general. And what this does is it just results in a decreased plasma level of those drugs, a quicker emergence of these patients, and sometimes an increased risk of awareness and recall in certain women. So that's one thing to keep in mind. And CYP34A encompasses a good majority of the drugs that are metabolized by the liver. So that's one area that can have some polymorphisms. Hair color is another thing that we always talk about, right? I'm not going to talk about dyed redheads, but natural redheads can be known to be quote unquote ultra fast metabolizers. And that specific enzyme we talk a lot about in pharmacogenetics, which is CYP2D6. That's a pretty common one. I'm going to elaborate on that one in just a second. Another thing is ethnicity. So Asians are known to be poor or very slow metabolizers, and they lack a lot of the enzymes that metabolize things like opioids and alcohol, or they have less of those enzymes. It's not all Asians, but some, and it's hard to predict too. You can give a seemingly normal or even lower dose of opioids, and those patients just will not come out of emergence, or take a really long time to metabolize that really small dose of fentanyl that you gave them. So these are generalizations and ways to help us predict who could be ultra fast or ultra slow. It's not to say that all redheads are ultra fast and all Asians are ultra slow, right? But that'll give us a clue as to maybe these polymorphisms show up more in these groups. Okay, so CYP2D6, that's something that we talk about a lot in pharmacogenetics. And there are really 4 main groups with this. And it depends on how many numbers of that gene allele is present. So you can, when you have the normal type, when you're normal, quote unquote, it means that you have 2 functional normal alleles for the CYP2D6. And we call those people extensive metabolizers. That's normal. You can actually have 3 or more of that normal allele. And what that's going to make you is an ultra rapid metabolizer. And for most drugs, with what this results in is decreased plasma levels of those drugs because you're metabolizing them too rapidly, and you need to increase the dose. Here's the caveat. That's for normal drugs. When you administer a prodrug, it's the opposite, right? Because a prodrug needs to be metabolized in order for it to be active. And if you give a prodrug to an ultra rapid metabolizer, they're going to have much higher plasma concentrations than what that drug was designed for. And one sad example of this is codeine in children, and why now codeine is not recommended for children at all of any age, because we didn't know which children were ultra rapid metabolizers. And for those of you who are unfamiliar, codeine is a prodrug to morphine. So if you give codeine to a child that's an ultra rapid metabolizer, their levels of morphine in their blood are much higher than they're supposed to be or intended to be. These children were given codeine post-surgically, sent home, going apneic, and then dying from it. So now there's a black box warning against codeine for children because of that reason. But that could happen in adults as well, right? You just don't know. So for prodrugs, giving prodrugs to ultra-rapid metabolizers can be pretty dangerous. To swing in the other way, so that's when you have 3 or more alleles. So if you could be heterozygous, so you can have one functioning allele and one abnormal allele. Those people would be intermediate metabolizers, and then you could have 2 abnormal alleles. Some of those people are poor metabolizers, and they, with normal drugs, can have pretty high plasma concentrations, and we need to decrease the dose for them. So that's the main, those are probably the main like board test kind of topics when it comes to the CYP 450 enzymes.
Well, I love the trail that you led us down to get there, because I think it's important to know all of the little things first, and then the big picture, rather, going into these little details for boards prep especially, but just in general. And I love how you mentioned the 2 main things that are most clinically relevant as well. Like, we can think about, my main thing with teaching my lectures is going to be like, why do we care? Like, why do we care about this? Like, because they all seem like very wordy things, or very, I don't know, can seem overwhelming with all of the information. But at the end of the day, like, how is this going to change the clinical picture or actual patient care? And I think you hit those perfectly. If you have a natural redhead come in, you have, again, those wheels start turning. Okay, what might this anesthetic look like? Or, yeah, codeine in children, there's obviously, we're not doing that anymore. Things change, and it's important to stay up to date in order to give the best patient care for these very important, seemingly overwhelming, wordy topics back into patient care. So I love how you tied that clinical picture back into it. So it's important to know how it affects us clinically. So what are some of the other common genetic polymorphisms that we see clinically that we can kind of talk about, especially for boards prep reasons?
Yeah, so there are some other genetic disorders that you should be familiar with when it comes to taking boards. There are about 6 that come to mind, and we won't go into all 6 of them into great detail. So certainly if you're listening to this, you want to learn more about that certain disorder, definitely reach out to Dr. Gomez and I, and then we can maybe make an episode on just those genetic disorders. Some of these genetic disorders are sex-linked traits, so X-linked traits, or they can even be autosomal disorders, so autosomal dominant disorders. One of them is glucose 6 phosphate dehydrogenase deficiency. It says G6PD. It's a mouthful. This is an X-linked trait that really affects your red blood cells. And basically you have a reduced production of this antioxidant called glutathione. And glutathione, the red blood cells actually have really hard time protecting itself against oxidative damage and stress. And so when you don't have that glutathione there to protect itself against the radical or the reactive oxygen species, basically your red blood cells start going through some severe like hemolytic anemia and going through surgery, and some of our drugs that we give can exacerbate it. So that's G6PD. The next one is acute intermittent porphyria. That is an autosomal dominant metabolic disorder. This is more deficiencies in your heme synthesis. So you have this accumulation of like these heme precursors. Most of the symptoms that patients have here are like neurological and GI type symptoms, and there are certain drugs that we give that can exacerbate this disease. So barbiturates, diazepam, ketorolac, sulfa drugs, that kind of thing. So that's AIP, or acute intermittent porphyria. Long QT syndrome. I don't think we talk about this enough. Sometimes quite a few people have long QT syndrome and we don't know it. So that's defined as a QT interval that's longer than I think 450 in males and 460 in females. And of course, we know that if you have long QT syndrome, you're going to have that increased risk for the polymorphic ventricular tachycardia, tachyarrhythmias like torsades. So these patients have like mutations in their potassium, sodium, and calcium channels. And then there's some medications that we give that can prolong this. ondansetron, certain anticholinergics, succinylcholine, dexamethasone. So you should be aware as to which drugs can prolong your QT. Another one is Brugada syndrome. So this is a type of channelopathy that affects sodium channels. It's actually in the gene CN5A, and you get this a certain pattern in your ECG. Of course, we're on a podcast, so I can't show you, but it's called a coved pattern. Just look it up. Brugada syndrome. You have this coved pattern on the ECG that is like very quintessential Brugada syndrome. This happens more often in males and Asians, and they can have sudden death, and then they can also have like really bad arrhythmias in the OR. So you need to have your AICD nearby. Usually they already have one implanted if they know about it. But I think the two that we're probably going to focus on a little bit more are the ones that are very relevant to anesthesia, which is your atypical pseudocholinesterase syndrome and your malignant hyperthermia. So with atypical pseudocholinesterase, you're going to have mutations to your enzyme plasmacholinesterase. And there's actually a test that you can do for this.
Yeah, so I'll talk about the dibucaine number. So this is, again, for boards prep purposes. It's super important and just in general. So I actually saw this clinically. I've seen both MH and pseudocholinesterase deficiency clinically. So I'm going to talk about the dibucaine number because we did draw it on this patient, but then I'll kind of go into the clinical picture because I find it really fascinating. So pseudocholinesterase deficiency, basically we do a lab draw. So we draw the blood and they take the blood, not we as anesthesia providers, but the lab takes the blood and they add dibucaine to it. So dibucaine is a local anesthetic. And when you add the dibucaine to blood, what's supposed to happen is it should inhibit 80% of pseudocholinesterase in the blood. And so in a normal patient where there's not a pseudocholinesterase deficiency, you'll see 80% inhibition. For patients, again, we talked about the heterozygous and homozygous deficiencies. We kind of mentioned how if you have one bad allele, that's heterozygous deficiency, that would be a like 40 to 60% inhibition of pseudocholinesterase in the blood. And then for homozygous, you have two bad alleles, that would be 20% inhibition. So what does this mean, right? Like that's when we get down to it, like, what does this mean clinically? And then I'll kind of go into like a little memory thing to where you can commit this to memory a little bit easier. So clinically, what we saw was a patient that had received acetylcholine, no other neuromuscular blocker intraoperatively that looked like they had received a neuromuscular blocker and wasn't adequately reversed. So this patient had respiratory effort, but it was that paradoxical breathing and the signs that floppy fish that we talk about in the OR a lot of the time. Unfortunately, we don't talk about it enough anymore because we have RYANODEX. So clinically, you look at the patient and you can see that the patient's struggling to breathe. And so we start going through the differential diagnosis, right? Like, what did we give the patient? Was it actually only acetylcholine? Was there something else administered that we accidentally administered, right? We kind of go through that differential diagnosis. We ended up taking over respiratory effort for the patient and then drew the dibucaine number. The patient had it was maybe like an hour, and then they were strong again, able to be extubated, recovered. I don't even believe that they kept them overnight. They drew the dibucaine number and the patient was super strong and was able to go home. Later, they kept him for like 8 hours because it was like first case of the day. So they watched him for an adequate amount of time and then discharged. So following up on that patient ended up having a heterozygous deficiency. So again, not that homozygous. So again, what does that mean? So that because that patient didn't have homozygous, if a patient has homozygous deficiency, they would almost have no respiratory effort. They would need intubation. Extubation or emergence would probably be very difficult. You would see those signs clinically a lot stronger, or ironically, not strong at all, right? So the patient would show signs of severe weakness in those cases. So a way that you can remember these numbers and this dibucaine number situation, again, for boards, is normal is 80% inhibition, right? So you look at the 80, and if you flip the 8 to the side, it's infinity. So if you think of that infinity, they have not infinite strength, but they're strong. And that's a good way to remember that they're good. But for heterozygous, it's half and half. So again, you have the one bad allele. Yep. So that's 50%. So the dibucaine number is 50. So that's a good way to remember that number because the dibucaine number is 40 to 60. So 50 would be a good way to remember it. And then lastly, the homozygous, you have two bad genes. So 20 would be the dibucaine number. So that's just a good way to remember it for boards. And that was my anecdote. Long story short, long story long, I guess. That was the clinical picture.
I actually saw one too. I was actually doing ECT which is electroconvulsive therapy. And for this patient, we gave methotrexate and succinylcholine. And after I pushed it, the psychiatrist goes, "Oh, yeah, this lady took a really long time to wake up last time." I'm like, "Thanks." After I pushed the medicine, because they could, they have to come in like 6 or 8 times to like get repeated therapy, right? So, and for ECTs, for those who have not done them before, you bag mask ventilate them the entire time. You don't intubate them or anything because you put them to sleep, and they induce the seizure, and then you give them a couple breaths and they usually start waking up. I'm bagging this lady for like nearly an hour because I'm like, what the heck is going on? Right, because it's supposed to last like 10 minutes, right? And I'm like, I think that she's got this like pseudocholinesterase syndrome. And sure enough, like she gets tested and she was heterozygous. Which heterozygous usually is going to usually affects people from like 1 to 3 hours. If you have homozygous, I mean, you're looking at like 24 plus hours where patients at that point would have to be intubated and, importantly, sedated. It's problems with being paralyzed, right? But they're still awake. So I felt bad because by the time I realized this, I'm like, oh, she's probably the whole time like awake but can't move, because we don't know what's going on. So yeah.
And I looked up the statistics. I don't know if you know off the top of your head, Rhea, like how this is pretty rare. Like this is not like super common. Like some people go like majority of their practice without ever seeing it. With that being said, I think I've seen like 2 or 3 times. So like, and anecdotally, they're like, "Oh, we had a patient today. Oh, we had a," and when we drew this lab, I was like, I don't think like I think maybe there was something else. Like just still not believing that this is what it was. And when it came back as heterozygous, I was like, oh dang, like it did happen.
Yeah. I haven't seen MH though. So, and you said you have. Yeah. So MH is just real quick for the audience, like it's actually autosomal dominant, and it's a mutation to this calcium channel called the ryanodine receptor, this RYR1 gene. And this calcium channel actually sits in your sarcoplasmic reticulum. Your sarcoplasmic reticulum is the endoplasmic reticulum that's in your muscles, but it's basically a warehouse or a storage center for calcium. You don't want your calcium to just be floating around the cytoplasm at all times because it can activate that actin-myosin interaction. So when you don't need calcium, it needs to be pumped out of the cytoplasm. So it gets pumped out of the cell or it gets pumped into the sarcoplasmic reticulum. When you have a problem with the ryanodine receptor, what happens is that when you give certain triggers like succinylcholine or volatile anesthetics, it actually causes that ryanodine receptor to extensively release calcium, and it impairs the reuptake. So you get this sustained muscle contraction. But what you said you had seen this in your clinical practice, I'm curious to hear what had happened in your scenario.
Oh, yes. And I'm going to do a whole other podcast on MH, and I'll share it a million times. It's going to be one of those stories that I'll just tell until I'm like 80, still IMH scenario. Yeah, it was a pediatric patient for anesthetic that they had received. I went in, this wasn't my case, but it was a case that I responded to as anesthesia code, essentially. They called for help. And when I went in the room, they had just diagnosed it. It was the end of the case. Luckily, it was a short case. But yeah, the patient was very hypercarbic. They had actually switched the LMA to an ET tube because they thought maybe it was a ventilation issue. The patient was becoming hypercarbic. So they went down like the providers that were involved were like, I wish I would have diagnosed it sooner. We could have done it sooner. And I'm like, you did the differential diagnosis. We don't go there. We don't go, this is MH. And, from the we have processes to like eliminate what's going on. And especially in a pediatric patient, you're like, oh, they're having a bronchospasm, or then they can put an ET tube in and gave albuterol. Like they did all of the things that they should have done. So the patient was hypercarbic. And again, the temperature was the late sign. So it wasn't until I walked in that the patient was like, I don't know, 8 climbing, but it was starting to climb like 0.1 degrees Celsius, like every couple minutes. It was starting to really climb. So we were like, okay, this has to be MH. So when I walked in, not that I was the hero of the scenario, but I really was like, let's get the crisis checklist to see what we've done and what we need to do. Because again, we don't see this very often. So like pretty much the only thing that we hadn't done was packing the armpits, axilla rather, and groin with ice packs, and then calling MHOS. And when we called MHOS, we had already given RYANODEX, which I had never given before. And it's basically all the providers in the room were like older providers. So even comparing the old dantrolene with the 60 mLs of sterile water, RYANODEX is much smaller. The dosage is the same and the calculation's the same, but it's a much more concentrated version of dantrolene, essentially, which none of us had even used RYANODEX. You pretty much hope you never have to give RYANODEX in a clinical.
Gosh.
But it was
Sounds
very
terrible.
interesting. I actually kept the vial. I think I might still have it, which is like kind of gross, but I did keep it because I was like, oh, this is so interesting.
Make it a Christmas ornament.
I'm thinking about it. I still have it. So yeah, as soon as we gave that RYANODEX, man, the patient normalized. I mean, it was like pretty within 20 minutes or so, the patient was stable. Like the hypercarbia had subsided or had climbed down. Obviously, like didn't come down instantly, but had trended down, and the temperature had also trended down. It was really amazing to see all of us work together and be able to, diagnose, treat, and see the progress. They kept the patient overnight, and the patient was discharged the next day. So it was pretty incredible to see, honestly. But anyways, yes, that was my clinical scenario with MH that I will be talking about until I'm like 85 years old, because you don't see it very often.
No, that's pretty cool. It's also cool to hear that the dantrolene is like not some like voodoo mysterious drug, and it actually works. That's pretty cool.
About when I did my the last podcast, ironically, about last, we talked about intralipids and like how they came to be, because like all of these emergency drugs are things that you just pray you never have to use and you never have to be exposed to. But ironically, when you do have to use them, it's a very stressful environment. So using checklists, using your colleagues, double checking dosage and what's actually going to be given to the patient is super important, because we just, again, don't do it very often.
It's pretty cool that you guys called M House too. And the fact that they answered. Yeah.
Answer. I'm like, who are you? Like, how do you just sit there all day? How many calls do you get a day? Like, went through basically the same checklist that I had. So we just went through there, like, you've done everything you can. Like, our recommendations are to, admit overnight, and they gave that recommendation, and that was it. So it was interesting to talk to them.
Yeah, definitely.
So let's talk, which topic do you want to go into next, Rhea? Let's do.
Probably we should talk about genetic testing and then kind of start to wrap it up from there.
Okay. So pharmacogenetic testing, can we talk a little bit about this? It's becoming more available, but how should we, as anesthesia providers, like think about this topic?
Yeah. It's kind of interesting. Other parts of medicine, they actually use genetic testing very frequently and all the time, but we're not using it clinically in anesthesia. That besides these couple scenarios that we talked about with, atypical pseudocholinesterase or MH, we're not really using it to guide our anesthetic right now, which is kind of a shame because, if we knew the patient's phenotype, especially their metabolizing phenotype, I think this would really help us dose our drugs more appropriately. But also there's this side of it, like, is the juice worth the squeeze, right? The cost versus the benefit, and how much are patients actually getting harmed by getting a little overdosed every now and then. And I don't think that we've really taken the time to study that. But, there are genetic tests out there to look at your CYP. And if, like I said, we knew the patient's metabolizer phenotype, this could help us dose our sedatives and our analgesics, especially our opioids, especially knowing something important like that CYP2D6 phenotype, whether you're an ultra rapid or a very poor, I think would be very helpful in predicting which patients probably could potentially be overdosed or underdosed. And that has real, clinical implications, right? If you have a patient that is not emerging from anesthesia or getting highly overdosed, they can have very toxic effects. If you have patients that are being underdosed, are those patients at risk for having recall during surgery because they're not getting enough anesthesia, but they're still being paralyzed? So those are like real scenarios that can happen to patients. Interestingly, I'm sure everybody's familiar with the name Drew Riddle. He's a CRNA. He was our ANA president a couple of years ago. He actually did a study in 2016, and the study's really interesting because he actually looked at CRNA attitudes towards pharmacogenetic. It's actually kind of a cool study. For those listening, look it up. And what he found was that the majority of CRNAs had very little or no knowledge about pharmacogenetic testing, and most of them were concerned about the ethical implications of it. So kind of interesting result. So that's CYP 450. Other things that we had talked about already, like malignant hyperthermia. So the RYR1 gene is just one of the genes that can cause MH. There's actually, I think, an upwards of like 20 more genes that can contribute. Another one that's more popular is the CACNA1S. It's a mouthful, but that's another gene that's often tested to see if patients are at risk for developing malignant hyperthermia. And then they can go on and get another test, which is that caffeine halothane muscle test to see if they react to the triggers. Just because you have a genetic variation doesn't mean necessarily that you have the disease. It just means that there is an issue with your gene, but sometimes it's not always like clinically relevant. We talked about plasmacholinesterase. Another gene that we can test for is the OPRM gene. These are variants in your opioid receptors. So that can affect your pain control, your opioid sensitivity. Other tests probably have more to do with drugs that we don't give as often. Like there are some tests for like warfarin metabolism that affects your anticoagulation, not as relevant for anesthesia. But like I said, there's a lot of like that study has mentioned, these ethical considerations when it comes to genetic testing, right? There's lots of things to think about when it comes to genetic testing and of course like privacy. Like genetic information is pretty sensitive information. Equity. Not everybody is going to have the same availability to get the tests than other people. So some people will have access, some people won't. Consent. Are people really fully informed as to what it means to get genetically tested? And what do those results mean to them and to the clinicians, right? If a patient finds out that they have risk factors for certain diseases, is that going to increase their anxiety? There could be like a psychological impact for that. And that's why there's always genetic counseling available. Discrimination. If insurance companies get a hold of this information, could they discriminate against patients? And even though there's the Genetic Information Non-Discrimination Act, it doesn't fully protect people. There's, insurance companies are like, they'll find their way around not providing insurance to people any way they can. So there's that. And I think also just from a researcher's perspective, like what do we do with these results? If we get results that say somebody is an ultra rapid or poor metabolizer, we still haven't really fully studied how we change our standard therapy based off of test results. Of course, it kind of makes sense that if somebody is a poor metabolizer or ultra rapid metabolizer that we adjust our doses, but it still hasn't been studied, right? So what if I say, okay, well, somebody tested as a ultra rapid metabolizer, I'm going to give them more medication than I normally would, or that's beyond standard treatment, standard of care. But then they ended up not being clinically relevant for that. Now I've just overdosed my patient, which I normally would not have done if I had. Do you know what I'm saying? Like that hasn't really been like tested.
Yeah.
Or supported. Yeah.
Just how clinically relevant it is. Exactly.
Yeah. So just a lot to think about still. I think we're still in the beginning phases. I could see it happening down the pipeline where we're getting more towards this personalized medicine. We're not there yet, but I think it makes sense for students now to just keep ahead of it and keep up to date with it.
Yeah, even now, when you were talking about this the entire time, I'm like, oh, maybe I should get my labs drawn or my, just to do myself. But again, that equity, I have obviously like connections and people and things, and not everybody has that. So I think equity is really important to keep in mind and how it affects us clinically and how clinically relevant it is. I keep tying in the clinical picture because that's what I'm the most comfortable with. But yeah, why do we care? Like, what are we going to do with this information is really important for students as well. So lastly, I ask every guest to just give me one piece of advice or encouragement, whatever you want to say to our learners. One little piece of advice. What are Rhea?
I don't know if this is going to be one little piece, but
a big piece.
A big piece. It'll be a big bite. So, I think that's just trying to stay relevant onto the topic. I'm just going back to the very beginning about the episode about what pharmacogenetics is all about. It's about, why different populations of people have different drug responses. And just always assume that there's going to be variability, and that variability is going to be always unpredictable. When you administer anesthesia, you could administer your anesthetic 99 times the same way to this one type of patient. And then on the 100th time you do the same thing, they act wildly different. And you're like, I don't understand. They're, the same BMI, the same genetic, the same sex, or the same ethnicity, or the same diagnosis, or the same, but they didn't, emerge from anesthesia. And it could come down to their genetic variability. So always assume that every patient you take care of is going to have a unique response. Don't get complacent with the way that you give anesthesia, right? So there can be a lot of like really unknown genetic variabilities and responses. I always tell students, because of this, just kind of having this assumption that everybody's unique and everybody's unpredictable, to really not underestimate the power of doing a pretty thorough preoperative review and looking for clues in patients and family history and personal history about any really unusual drug reactions like prolonged paralysis, unexplained fevers, adverse drug reactions, prolonged emergence, just any kind of hint that they have some kind of hereditary conditions. Always start low and titrate slowly. Be conservative with your initial drug doses and always titrate. Never just slam in your big dose all at once. Go low and slow. And keep in mind also that incorporating something like a multimodal technique really does reduce the dependence on a single drug class to take care of whatever you want to take care of. So you're going to avoid any kind of excessive dosing and you're going to avoid any kind of toxicities there. So try your multimodal. So low and slow multimodals. Always be prepared for any kind of adverse event. Prolonged emergence, respiratory depression, excessive sedation, even the rare instances of MH and atypical plasma. You just don't want to get complacent, right? You just think that these things can happen at any time. I think another thing to kind of wrap this up is I don't think we do a good enough job communicating our findings with future care teams. So I don't think we do a good enough job of like really being detailed in our charting, but also sharing our findings with family members and saying like, hey, this unusual thing happened. And we need to make sure that when they have future clinical encounters, when they go to future care teams, that those care teams know this information. So yeah, that's my like summary of just things, like best practices for students out there. Of course, like your podcast says, lifelong learning is a huge thing because this is still such a new field. Keeping up with pharmacogenetics and personalized medicine, it is the future of medicine. So, you want to be that clinician that understands it and is able to incorporate it well into your practice.
No, I love that. The titrate and weight is what I always tell students too. So I love that you mentioned that. And I appreciate your time and all of your expertise in this. I mean, I learned a lot. I know the listeners learned a lot as well, and they're one step closer to being prepared for boards. So I appreciate your time, Rhea.
Absolutely. Thanks for having me on the show.
Yeah, of course.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.